Okay, um, we have a lot of commonalities between these conventional antipsychotics, so we will go through some of these quickly. So let's talk about a fluphenazine. So fluphenazine or prolixine, it has a generic. It is used in USA, so it is a conventional antipsychotic. Of course, it is from the if it is a kind of neuroleptics called um, phenothiazine. Okay, so it is used for psychotic disorders as approved, and it can be used in bipolar disorders off label. Okay, it takes I will go through. You can get back to chlorpromazine. We've talked about a lot of things right there about atypical and about conventional antipsychotics. But now I will go through some of these conventional antipsychotics quickly for special things about them. So yes, psychotic symptoms can improve within 1 week, but it may take several weeks for full effect or on behavior. Um, okay, what to do if it does not work, how can we augment, what tests we need. All of these are general here. Yeah, about all conventional antipsychotics, the same thing. Okay, what about side effects? The same thing about side effects here. There's nothing special here, but you can remember this priapism is an side effect here. It is also mentioned in other conventional antipsychotics, but just to remember. It's not usually causing weight gain and not a sedating agent either. So the dosage here, if we are talking about fluphenazine, it is 1 to 20 milligram per day in maintenance for oral. Intramuscular, generally 1/3 to half of the oral dose. The cannulate for intramuscular or subcutaneous administration would be 12.5 to 100 milligram divided by 2 weeks, every 2 weeks maintenance. So we'll talk about that in a minute. We have a lot of dosage forms. We'll not go through them. How to dose? You initially start with 0.5 to 10 milligram per day in divided doses to the maximum of 40. Intramuscularly, for short acting, you can start with 1.25 to anyways, here we have some tips. Patients receiving atypical antipsychotics may occasionally require a top up of a conventional antipsychotic to control aggression or violent behavior. Fluphenazine tablets 2.5, 5 milligram and 10 milligram contain tartrazine, which can cause allergic reaction, especially in patients sensitive to aspirin. Oral solution should not be mixed with drinks containing caffeine, tannic acid like tea, or pectinate apple juice. Treatment should be suspended if absolute neutrophil count falls below 1000. Overdose is the same for other typicals. How to stop is the same here. For pharmacokinetics for this fluphenazine, the mean half-life of oral formulation is approximately 15 hours, and the mean half-life of intramuscular formulation is approximately 6.8 to 9.6 days. Drug interactions are similar to those with other antipsychotics, other typical antipsychotics. You do not use this drug if patient is in comatose or CNS depression. If the patient is taking cabergoline, pergolide, or metrizimide. And if there's any, of course, allergy to fluphenazine. Okay, or any sensitivity to other phenothiazine. But special populations you use with caution in hepatic and renal impairment, and you should, titrate slowly. That's it. Cardiac toxicity can be occur, so be aware of that. In elderly, you should be cautious, of course. Safety for children and adolescents are not established. Okay. And the cannulate injectable formulation are contraindicated in children under the age of 12. So you consider other drugs. Okay, so let's go there to the art of psychopharmacology here. You can use intramuscular formulation for emergency use. We are talking about the short acting, okay, for emergency use, and relatively rapid onset of even the long acting injection. But see, fluphenazine, the cannulate after pills, we will talk about that in a minute. These are the advantages here. Disadvantages are, for tardive dyskinesia, children and elderly. The primary target of symptoms are positive symptoms of psychosis, motor and autonomic hyperactivity, violent or aggressive behavior. Here are some pills. Fluphenazine is a high potency phenothiazine, so you should know that, high potency. Less risk of sedation and orthostatic hypotension, but greater risk for extrapyramidal symptoms than with low potency phenothiazine. Okay. Not shown to be effective for behavioral problems in mental retardation. Patients have very similar antipsychotic responses to any conventional antipsychotic, which is different from atypical antipsychotics where, patients with inadequate responses to atypical antipsychotics may benefit from trial of augmentation with a conventional antipsychotic, or from switching to another conventional antipsychotic. Okay, all of these are general. So let's talk specifically about fluphenazine decanoate. Fluphenazine decanoate. The vehicle is sesame oil. The Tmax is 0.3 to 1.5 days. The half-life with multiple dosing is 14 days. Able to be loaded, yes. Time to reach steady state is 4 to 6 weeks with loading. Dosing schedule and maintenance would be every 2 weeks. Injection site intramuscular or subcutaneous. Needle gauge 21. Dosage forms 25 milligram. The injection volume would be 25 milligram per milliliter. Okay, so the usual dosage range, we are talking about long acting, of course, the cannulate, 12.5 to 100 milligram every 2 weeks maintenance. How to dose? Conversion from oral, can either supplement with oral formulation at half dose for at least 2 weeks, or use weekly loading injections of 1.6 times the oral daily dose, milligram per day, for 4 to 6 weeks. Some dosing tips with long-acting injections. The absorption rate constant is slower than the elimination rate constant, so thus resulting in flip-flop kinetics. It means time to steady state is a function of absorption rate, while concentration is a steady state. At steady state is a function of elimination rate. Okay, time to steady state is a function of absorption rate, while concentration at steady state is a function of elimination rate. In general, 5 half-lives of any medication are needed to achieve 97% of steady state levels. The long half-lives of depot antipsychotics mean that one must either adequately load the dose if possible or provide oral supplementation. The failure to adequately load the dose leads either to prolonged cross titration from oral antipsychotic or to subtherapeutic antipsychotic plasma levels for weeks or months in patients who are not receiving or adhering to oral supplementation. Because plasma antipsychotic levels increase gradually over time, dose requirements may ultimately decrease from initial. Obtaining periodic plasma levels can be beneficial to prevent unnecessary plasma level creep. The time to get a blood level for patients receiving LAI is the morning of the day they will receive their next injection. Advantages: early peak, see the following graph, we'll talk about that, may be beneficial in management of acute patients. Disadvantages: early peak also carries risk for extrapyramidal side effects or akathisia in the first 48 hours. So 2-week injection schedule, a higher incidence of local site injections due to sesamoil oil vehicle. Okay, all of these are disadvantages. Response threshold is 0.81 nanogram per milliliter. Plasma levels greater than 2 to 3 nanogram per milliliter are generally not well tolerated. So we need just 0.81. This is actually the threshold. Okay, switching from oral antipsychotic to fluphenazine decanuate. Here we have the the fluphenazine decanuate single dose 25 milligram kinetics. Here we have the plasma fluphenazine concentration and the time in hours. Here we are talking about this concentration that is rising, and then okay, this is early peak that may be useful in acute situations, but then steep drop that requires loading or oral coverage not to get below the level that is the response level, which is as we said 0.81. So discontinuation of oral antipsychotic can begin immediately if adequate loading is pursued. Otherwise, supplement with oral formulation at half dose for at least 2 weeks. How to discontinue oral formulation? Down titration is not required for amisulpride, aripiprazole, piprazole, cariprazine, or paliperidone ER. 1 week down titration is required for iloperidone, lorazepam, risperidone, and ziprasidone. 3 to 4 weeks down titration is required for asenapine, olanzapine, and quetiapine. 4+ weeks down titration is required for clozapine. For patients taking benzodiazepine or anticholinergic medication, this can be continued during cross titration to help alleviate side effects such as insomnia, agitation, or psychosis. Once the patient is stable on LAI, these can be tapered one at a time as appropriate. So that's all about fluphenazine. We talked about the most important things here, so let's just skip that. Here we have some, suggested readings if you are interested.